Good morning. I'm going to talk to you about the use of urgent start peritoneal dialysis, particularly as a way of getting more patients onto peritoneal dialysis. So the outline of my talk, I'm going to talk about the falling numbers of patients on PD, late presentation with end-stage renal failure, and the failure to use PD acutely. Summarize the international experience of urgent start PD, talk about our experience at King's of the acute start PD program, briefly about the use of acute PD for COVID-19 associated AKI on the ITU in the past 6 months, and then finish with a case presentation. So people will have seen this graph before from the UK Renal Registry, basically showing the progressive increase in the number of patients with end-stage renal disease, but how the numbers on hemodialysis and with a functioning transplant has increased, whilst the absolute numbers of patients on peritoneal dialysis has fallen, and certainly even greater the percentage of patients with PD as their RRT modality. So what are the reasons for this? Well, PD has a bit of a limited lifespan. It's easier for the nephrologists to start patients on HD. There's some anxieties about EPS, passive versus active patient involvement, and the failure to use PD in late presenters, so-called crash landers. So if we look at the late referral for RRT, we know that it's a relatively high percentage, so between 20 and 50%. In fact, in the UK, the incidence of true crash landers has fallen progressively. In 2005, it's 28%, and by 2017, it had fallen to 18%. But of course, in addition to the true crash landers, we know that every renal unit will have known patients who also present late, either because of poor compliance, adherence, non-attendance, or because, for example, they were for so-called conservative care and then they changed their mind. This is the same renal registry data, just presented graphically, and you can see that the bottom on the blue, the numbers of patients or percentage of patients has fallen progressively. We know that if you present late with end-stage renal failure, you have a higher mortality than patients who've been followed up by renal units for some time. This paper in the American Journal of Medicine demonstrates that the 3-month mortality is higher in the early referral group, and this is also true at 5 years. A variety of reasons for that, of course. And we also know that the patients are less likely to have peritoneal dialysis. This is renal registry data. So if you present late, only about 10% of patients will have PD, and whereas early referral, it's much higher. And that's true both early on and even at 90 days. So why do we fail to use PD acutely? So starting hemodialysis is actually much easier for a nephrologist. The junior staff are trained to insert vas caths, either femoral line or internal jugular vas caths, and that's very easy to organize. And of course, we know in most renal units, the nursing staff will do acute hemodialysis either during the day or night. People perceive there as being issues related to consent. So there's thought to be no need for consent for long-term hemodialysis. In an acute sense, you can just put a vas cath in and then talk to the patient subsequently, whereas it's thought that for peritoneal dialysis, this is not true, and the patient requires detailed consent. And then in addition, because PD is a treatment patients do at home, we worry about their housing situation, etc. And this can make people say, oh, we can't start PD because we don't know whether they'll be able to do PD in the future. People have a lot of worries about inserting PD catheters and using them acutely. They worry they will leak if you use them acutely, although we feel this is both a minor complication and pretty unusual if patients are managed correctly. There's difficulty of getting a PD catheter in. If it's done by the surgeons, you have to involve another team, whereas a junior renal doctor will put in a VAS cath. And of course, if patient has very poor biochemistry, there's always the problem of giving a patient a general anesthetic before they have any dialysis. And then finally, of course, there's the fear of the unknown. Many patients will start with acute HD, and then once they've had HD for 1 or 2 sessions, it becomes the known treatment, and therefore the patient is understandably anxious about having a new line, which would be the PD catheter, and starting a new treatment. And then, of course, PD, of course, is an active treatment where the patient's actively involved, whereas the patient will perceive hemodialysis as passive. So what about the international experience of acute start PD programs? This is from a Danish group who have published extensively on use of acute PD. This particular paper is a summary of their experience. And basically their conclusions are that if you use a PD catheter acutely, you do have a higher risk of mechanical PD catheter complications, but this doesn't have any effect on mortality, technique failure, or infection rate. And they say that in their experience, the mortality of patients on acute PD is very similar to acute hemodialysis. This is a Brazilian study in 51 patients with unplanned ESRF start, where they started PD within 72 hours. Mechanical complication rate was relatively high from the PD catheter, but technique survival at 6 months was very good at 86%. And again, they conclude that acute PD is safe and is an effective alternative to acute hemodialysis. This Canadian study, 33 patients started within 2 weeks. 3 patients, so 10%, had a minor PD leak, which was managed conservatively. And again, they conclude that acute PD is an acceptable alternative to acute hemodialysis. This is a French study where they're comparing acute PD with acute HD, although not randomized, but 1-year survival was very similar in the 2 groups, and the initial period of hospitalization was the same. German study, again comparing acute PD with HD, 6-month mortality was the same in the 2 groups. Mortality due to infection was higher in the HD patients, but that was not significant, and the bacteremia risk in the hemodialysis patients was probably not surprisingly higher. And then this is a big study from Shanghai. 657 patients started PD, and of those 344, slightly more than half, started to use the catheter within 7 days of insertion. Their mechanical complication rate was higher in the early starts, although not as high as in that previous study at only 8.4%. The need for surgical intervention was no higher if they used the catheter acutely, and technique failure was not related to early use. So what about our experience at King's? So this is over a 5-year period to the end of 2018, 76 patients acute start PD. Quite a wide age range. Most of them, in fact, were failed conservative care or non-attendance rather than true crash landers. All the patients had a LA catheter insertion. 66 of the 76 started within 4 days, and the remaining 10 within 4 to 7 days. 4 patients, so less than 10%, had leaks in the first 2 weeks. They all resolved with conservative management. And in fact, they all occurred because of the patient getting up and walking around with PD fluid in, and we've become much stricter in that over the last 5 years. 5 of the patients were saying had PD for less than a month and switched to hemodialysis. We would argue this is not a failure of PD any more than if a patient switched to PD from HD within 2 to 4 weeks, we would say that's a failure of HD to do what it was supposed to do. And then just to turn to our experience of COVID. So we know that COVID-19 hit the UK and particularly London pretty hard in March this year. And King's, which is in central London, very quickly had a large number of patients on ITU requiring ventilation because of COVID. This graph is what happened at King's, and so this line here is our normal ITU ventilation capacity, and this line here is our normal ITU capacity, and these are the patients with COVID requiring ventilation on ITU. And as you can see, we pretty quickly had large numbers of patients, and we exceeded our normal ITU capacity quite quickly, and that's just with the COVID patients. And we only achieved this by opening new ITUs scattered around the hospital. A great deal of work, obviously. And then the other thing that became clear was that AKI was much commoner than we'd originally thought. The Chinese data suggested it was only about 2%, but the UK and the Western world data indicated that it was much higher, between 25 and 50%. And this led very quickly to an initial shortage of CVH machines. King's initially only had 23, although they increased that up to about 40. So we ran out of machines, and then we started to run out of consumables. So we ran out of filters, and then we started to run out of fluids. And that was both a local problem, it then became a national problem, and then became an international problem. So we had to think about alternative forms of renal replacement therapy. This is the published data on the use of acute PD in ITU to manage acute kidney injury. These two papers are on the left from Brazil. This paper here is from Thailand, and this is from Saudi Arabia. This is also Brazil. So these two papers and this one over here are comparing acute PD with either daily HD, extended HD, or CVV-HDF. And basically, conclusions are in these two studies that outcomes are very similar, as you can see, in terms of mortality, whereas this Saudi paper with about 60 patients in each group, it was a randomized study, demonstrated that the survival, in fact, was better in the peritoneal dialysis patients. And the reason for this is quite interesting. So we decided to do acute PD. We decided very early on that we'd only put catheters in under local anesthetic, partly because that's what we're used to doing, and partly because we just thought we didn't have the bandwidth, the time, or the energy to involve the surgeons in this. All the catheters were put in either by a nurse or a consultant nephrologist, although we did start to recruit an interventional radiologist, partly as a proof of concept towards the end of the outbreak. We put the catheters in ITU. All the patients were already sedated and ventilated, and therefore consent and analgesia was not really an issue. Perhaps aware that ITUs stopped allowing family to visit, and therefore getting consent for what they perceived as relatively minor procedures was put aside. We used our normal selection criteria, and in particular, we don't like patients to have had a significant previous abdominal surgery, particularly with scars around the umbilicus. We normally have a BMI limit of 35, but we relaxed that a bit. Constipation is always a major issue on ITU. We gave all the patients citrafleet twice in the 24 hours prior to catheter insertion. We usually give vancomycin, but a lot of the patients were already on broad-spectrum antibiotics. So what happened? So we attempted to insert catheters in 43 patients. We were successful in 36. In fact, we put in 37 catheters because one patient had a catheter, recovered function, had another episode of AKI, so had a second PD catheter inserted. We failed in 7. In 2, we think we got into the peritoneal cavity. 1, we just couldn't advance the wire. And in 1, we aspirated air, indicating we'd gone into the bowel. So we withdrew or abandoned the procedure. The patient was fine and went on to CVVH, and they didn't have any abdominal sequelae. And in 5 patients, we couldn't get into the peritoneal cavity because of their obesity. So median age 60, large majority were men, as in keeping with what we know, the majority were Black and ethnic minority, BMI relatively high and skewed to the right, and there were a lot of comorbidities, as we know. So in terms of complications, so basically the PD worked well, but we had no abdominal wall leaks, we had no exercise or tunnel infections, and we had no episodes of PD peritonitis. One patient had a scrotal leak after 3 days. We switched to CVH, removed the PD catheter. He remained fine, and in fact recovered renal function and was discharged from hospital. 2 patients had minor bleeding from the PD exercise, which just settled. And there were interestingly minimal problems with PD drainage because we'd anticipated this to be a big problem. One patient had a profound ileus. We continued PD through that, and it resolved after 3 to 4 days. So all patients had APD. We did think initially that we might do some CAPD, but with what was very rapidly a large number of patients, we realized we just didn't have sufficient staff, and the ITU staff were not trained to do CAPD. So we only did APD. We used exclusively Baxter home choice or Claria machines, and Baxter were very generous in getting extra machines for us. Initial regime was 20-liter as an overnight dwell with a dwell volume of 1.2 to 1.6 liters, depending slightly on the size of the patient. Dwell time was 40 minutes. The glucose concentration was determined by the need for fluid removal. And in fact, acute PD is very effective at removing PD fluid. All patients, obviously, we had daily review of their biochemistry and how the dialysis was working, and we adjusted their volumes, usually up to a maximum of 30 liters, and we adjusted the dwell time. And then if we needed to remove more fluid, we would adjust the glucose concentrations each day. So this is what happened. This is the same graph you saw earlier on. The colored things here are the patients requiring RRT. The green is peritoneal dialysis, and then the blue subsequently is in ITU, intermittent hemodialysis. And as you can see, we quite quickly had large numbers of patients on peritoneal dialysis, and we were able to, even though the numbers of patients requiring RRT didn't really fall, the number of patients on CVVHD we were able to bring down very successfully with our both acute PD and acute intermittent hemodialysis. So what were the issues? Well, it was a lot of work. It was very time consuming, both reviewing patients, inserting the PD catheters. We feel that PD catheters can be inserted in this sort of scenario by whatever technique the local renal unit team has experience of. We found acute PD, LA PD catheter insertion worked very well. It was a very high workload for the PD staff. ITU, particularly in COVID and with all the PPE, is a physically very demanding environment. It was very time consuming, putting on and taking off the PPE. Communication when you're in full PPE can be very, very difficult. We were very lucky to be able to recruit PD staff who were working elsewhere in the hospital back to the service, so we could provide a 7-day-a-week service. And my consultant colleagues were all very helpful in contributing to the service as well. We found moving PD, the volumes of PD fluid around the hospital. If you have 16 patients on PD, each using 20 to 30 liters a day, that's a lot of fluid to move into ITUs. And then there were big issues about the education of and liaison with the ITU staff. Multiple ITUs, lots of staff. There were some issues with machine alarms and drainage, and particularly lack of staff experience, although that gradually improved over time. The other issue is that, of course, the ITU team are very used to using CVVHDF, and the power of that in terms of controlling biochemistry and hour-to-hour fluid removal, and it took them a while to understand the benefits and limitations of peritoneal dialysis. As a result of this, we've talked to various units around the world who've also done acute PD, and it has been very successful in some ITUs to limit the number of patients requiring CVVHD. This paper at the bottom is from New York, and as you may be aware, New York had terrible problems not being able to do enough renal replacement therapy, and they did in fact have some patients die of renal failure because they couldn't do RRT. And this one unit did 33 patients on PD. Their experience was very similar to ours, although they put all of their catheters in under GA, and the PD program was run really exclusively by a group of nephrologists, as they didn't have the nursing staff to do it. So I'm just going to finish with a case presentation. This is a young man, 26, not known to renal services, Black African ethnicity, but born in the UK, presented in November 2017 with a several-week history of nausea, headaches, lethargy, and edema, and was found to have severe impairment of kidney function, a bit hypertensive. Kidneys were normal sized on ultrasound, and his immunology was all negative. The ward team had been planning to do hemodialysis via a femoral line prior to doing a kidney biopsy the following week, but our PD sister happened to be on the ward, overheard the discussion, said, oh, we think we should give him PD, spoke to the patient. She came back in on Saturday morning, inserted the PD catheter under local anesthetic. We used it that day. Because he was overloaded with fluid, we removed 2.7 liters of fluid in that 24 hours. And that's something that acute PD is very effective at doing. Patient was kept in until early the following week because he had a kidney biopsy, and then he was discharged to have outpatient peritoneal dialysis and to start training. Kidney biopsy interestingly showed IgA nephropathy. So he remained on PD for 8 months, and then because of poor compliance, which is not that uncommon with young men, he was switched to hemodialysis. So what are the issues from this case? Even in a unit which is keen on acute PD, it's much easier for the ward staff to start acute HD. If you're going to do acute PD, we think you need to make the PD catheter insertion pretty straightforward. Either it needs to be done by the renal team, or you need to have very compliant surgeons. It's much easier if the catheter, we feel, is inserted under local anesthetic, because you don't get into issues of having to have a GA with poor biochemistry, etc. We find being able to insert catheters at weekends is useful, although we don't do it that often. We only come in maybe 2 or 3 or 4 times a year to put in a PD catheter. But it does just mean that the consultant body as a whole are aware that they can put catheters in at weekends, or if that comes to that, remove them. And as I said, acute PD can remove fluid very effectively. So what are our conclusions? So I think we need to be considering PD in all late presenters. I feel that a local anesthetic PD catheter insertion is very similar to an HD line. The risks are probably similar, if not perhaps lower, and I feel it has fewer long-term sequelae than either a vas cath or an internal jugular line. One of the other benefits is that if you return, when one returns data to the renal registry, if you start a patient acutely on PD, it means the patient started their renal replacement therapy story using permanent access. We feel that fully informed consent for PD is really similar to HD, and you can't do it fully acutely, and therefore one just needs to accept that. We feel that it's very useful to be able to do outpatient APD and to provide assisted APD initially for these patients, because it enables you to get them home but continue with PD and therefore not block beds. As we've said, leaks should be uncommon. They really occur because patients get up and move around when they have fluid in their abdomen. And of course, that's probably why we had no leaks on ITU, because the patients were all lying flat on their back. And then finally, I suppose, just to say that if the patient switches to hemo after weeks or months of peritoneal dialysis, it's not really a failure of PD any more than it would be a failure of hemodialysis. So thank you very much.